Nasal polyps, is there any help in sight? Previous times I've called this panel nasal polyps our nemesis, and I feel like they truly are. It's a humbling experience, but for those who weren't here yesterday, my panelists, Arif Janjua is a good friend from University of British Columbia, Jivian Lee, as you know, from UCLA, Kevin Welch from Northwestern, and then Drew Ayers is my go-to allergist at University of Washington, and he alone has increased my IQ by at least 6 points, I think. So he's the cognitive side of what we do. And
low bar, though.
Well, I know. It's lots of room for improvement. Yeah, my wife tells me that all the time. This is not today, but on about 2 days out of the year, the University of Washington is a beautiful campus to walk through. But I captured these photos just to remind me why we live here. It is a beautiful place. I would like to plug this again, and I'm going to try to continue to brainwash you. I'm not a course chair for Rhino World. I'm a course chair for Summer Sinus Symposium. Many of you were at it last summer. We're combining a light version of Summer Sinus Symposium, which is free for ARS members. I know several of you are members. Several of you members also haven't paid your dues, and I was supposed to talk to you about, I'm looking at you right now. But Summer Sinus will be in Miami in 2020, but we're doing a light version attached to the front end of Rhino World, which will actually start the 5th of June for Summer Sinus Symposium. That's a Wednesday, and then we'll morph into Rhino World, the largest rhinology meeting every decade, and that will be in Chicago, so I encourage you to register soon. These are the concepts that I tell my patients, and when I learned this, 5, 6 years ago, it made me a happier person because we can't cure polyps, right? The day we cure asthma, we cure nasal polyps. That's what I tell my patients, and most of them have asthma anyway, and surgery is not a cure for inflammatory sinus disease. But to my colleagues, I say complete sinus surgery is what facilitates a topical therapy. It doesn't mean a total ethmoidectomy where you're doing some holes into the anterior and some holes into the posterior ethmoids. It means complete sinus surgery, and I'm going to show you some examples. And that's a huge difference to take it from a total ethmoidectomy to a complete ethmoidectomy, where you're really getting along the lamina, the skull base to the middle turbinate, taking all those periorbital cells down. And then we need to do better than just recommend surgery. And this is what I learned from Dr. Ayers. Truly, 10 years ago, we would just operate on these patients, but there's so much more we need to do. We need to invoke that medical doctor side of us when we see these complex polyp patients, or at least we need to team up with a super smart allergist who can fill in our deficits, and that's where Dr. Ayers comes to play. I'd like to talk about a case and really beat this one up because it's a case that half of it's hypothetical, half of it's real. But it's a classic patient that we all see, a 48-year-old gentleman, that's real, complained with bilateral facial pressure, nasal congestion, and drainage for 20 years. He's had a couple sinus surgeries. Every surgery he gets better for a little while, so he does gain some benefit from it. But the symptoms always come back. And 2 years ago was his last sinus surgery done outside, and he's had multiple courses of antibiotics, probably culture-directed antibiotics or not, and prednisone. Prednisone helps for a while, but then he comes back. So, you look in the nose and you see this, and you think, all right, well, what else do we need to do to manage this? What else do we need to know? And I'm going to start with Arif. So what kind of history from this presentation should we ask?
We got a little bit of history about the duration and the nature. I don't know if we got an allergic history from him, but obviously it plays into the idea that this is a chronic inflammatory condition of the nasal lining, and that the reason he's getting relief when he gets either surgical debulking of these polyps or chemical polypectomy in the form of prednisone is that we control that inflammation, we shrink things. But then when we didn't hear anything about his topical therapies and his ongoing maintenance, whether that be saline nasal irrigations, intranasal corticosteroids. But we need to know a little bit about how he is planning or has been counseled about controlling this ongoing inflammatory condition on a day-to-day basis.
Okay, and then what other comorbidities? You mentioned allergies. Dr. Ayers, what do you think? So a patient with known polyps, in your opinion, non-biased of course, should all patients with polyps be tested for allergic rhinitis?
We usually do, but the standard therapies for allergic rhinitis don't really, cover this. And I say allergy shots. We always talk about that, but I say there's a good chance, even on allergy shots, it's not going to cure the nasal polyps. We usually will test them, especially if they have other symptoms of allergic rhinitis, sneezing, conjunctivitis, things like that. But it's something we always look into, we test for, we try and treat. But I tell these patients, even on immunotherapy, and it's a long course, 5 years, I can't promise that it will control your nasal polyps.
Dr. Welch, any other comorbidities that you would suggest we ask the patient about?
No, I can't remember if it was on the interest slide, but asthma. 30 to 60% of patients with nasal polyps will have asthma, so that's the first thing I start thinking about. And oftentimes patients say that they don't have it, but if you query, they tend to have cough, or sometimes their primary doctors have given them albuterol and they use it for exercise-induced stuff or some other things. But I think a large percentage of these patients do have asthma, and that sort of keys in, and I'll talk about this a little bit later, into what types of pathology these patients have.
Right, so this patient has polyps, they have asthma. Is there anything else that they might have to complete that triad? Dr. Lee.
Aspirin sensitivity.
Aspirin sensitivity, thank you. So Dr. Ayers, should we be asking all of our polyp patients if they have problems with aspirin or NSAIDs? And if so, what specific questions should we ask them? What defines a problem with aspirin sensitivity?
I tell our fellows, anyone that comes in with nasal polyposis or even our asthma workshop, you should ask about NSAID sensitivity. Specifically, and I'll go over this in my talk next, sinopulmonary symptoms are the big things. If they just have urticaria, they just have GI symptoms, it's less likely to be the triad that I'm going to go over in a second. But specifically sinopulmonary infections within half hour to 3 hours is classic for the triad or aspirin-exacerbated respiratory disease. So again, I tell our fellows, ask every new asthmatic, every nasal polyp patient, have you had aspirin? Have you had ibuprofen recently? And if so, did you react?
And I appreciate that. And again, something I learned from him, we didn't really used to ask these patients, and now as my residents know, in my template, they have to ask. It's 3 stars in EPIC. You cannot pass go unless you ask about aspirin sensitivity. And it's amazing how busy your aspirin sensitivity clinic is now, and I know you're going to talk about that, so I'm hoping our panel and your discussion will chat about that. So what other workup do we need at this point in time to complete the picture? You've done a good history. Is there anything else that's needed? You've looked in their nose. You see grade 4 out of 4 polyps. Arif, or anybody?
We need to get the additional idea about the degree of the inflammatory disease, the extent of the polyps, what previous surgery has been done, because I think he's had several, to give us an idea beyond the history and physical.
Okay. This is always interesting when you try to use this. So here's a CT scan, and it'll just cycle through a couple times. And it's pretty obvious. He's got the sinus. He's got polyps. And it'll keep playing around, and just to cut to the chase. So there's no dehiscent areas. Anything else? So we have a CT scan that looks really bad. He's failed appropriate medical therapy. Nasal endoscopy confirms. Any other things we need? Or are we ready for the OR? Dr. Ayers, what other things would you order in your clinic that now I order in my clinic because you've taught me?
Eosinophils.
Eosinophils.
And IgE level as well, which you guys are great about sending. Also asking about asthma history. How severe is their asthma? Is it controlled? And what therapies on there? Because depending on that, there may be other options available.
Great. And so just like that, because I've learned from my allergist, his IgE level was high and his absolute eosinophil level was not too bad. Dr. Ayers, is there a cutoff where, just because the number is red or abnormal, does that mean we should refer to an immunologist?
That's actually a pretty good eosinophil level. The cutoff for the biologics, and I'll go over this, is 150 or 0.15. That 1.1 is a pretty decent level. So yeah, if you see that level, if they have nasal polyps and they have asthma, there are other treatment options that could be available.
Great. And it doesn't necessarily mean we have to do the MABs, and you're going to chat about this, but we have to be smarter than just cutting out the polyps. We have to be more than a surgeon in these patients. We have to change what hasn't worked for these patients in the past so that they have a different outcome. All right, Dr. Lee, at this point, are we ready? Ready to operate? Anything else we want to do medically before tee it up so to improve our chances of success afterwards?
Well, I think it's reasonable to give the patient some preoperative steroids if we're planning on doing surgery. I think it helps to reduce the polyp burden. There's been some evidence to show that it reduces the amount of bleeding at the time of surgery. I also wasn't sure if the patient had been on any maintenance topical steroid therapy in between surgeries. Obviously, I think that that's incredibly valuable in terms of optimizing our long-term surgical outcomes.
I just want to say I want to get buy-in from the patient at this point because this is a long-term problem. And I want to make sure that they're willing to go through the surgery, the postoperative debridement, and the postoperative irrigations, or whatever chronic medical therapy we can give that patient. Because if this patient's not willing to do that, in 6 months or a year, he's going to be in a pretty similar situation. And then, in my estimation, that's really not worth it to go through all that if the patient's not willing to go through that.
I like the word buy-in. I think engagement, we want to engage them as part of their care because this is not something that we solve with surgery. Surgery is an avenue to get medication in there and potentially give them some avenue for improvement, but if they're not going to do anything, it's not worth their time or yours to keep going down this path of multiple surgeries and recurrences.
Okay. I love the buy-in that surgery is not a cure for nasal polyps. Thank you. Dr. Ayers, what about leukotriene inhibitors? Should the otolaryngologist be prescribing those when they see patients like this with asthma, or should we defer that to the allergist or the otolaryngologist who does allergy?
With asthma, sure, there's relatively low risk. It's a very safe medication. It's generic. It's cheap. I tell patients it's probably not going to have a significant benefit, although some people do get improvement. Specifically with asthma, yes, we usually will start those as an add-on therapy, especially if there's an exercise-induced component. That's specifically where they work really well. But it's never a bad thing to add Singular because it is a very, very safe medication.
And is there a reason why you're choosing Singular over the other leukotriene inhibitors?
There's other ones. There's 5-LO inhibitors. You have to monitor liver function on those, so it's much tougher. So, and they are much more expensive. We usually start with Montelukast just because that's the cheapest, most readily available, and that's what we use for asthma most often.
All right. Dr. Welsh, what surgery are you going to recommend for this patient? What are you going to consent for?
Most likely, a complete everything, and I would include in that a Lothrop and a medial maxillectomy. And I guess looking at that patient's sphenoid, I would certainly consider drilling that sphenoid.
So you're doing a mega everything.
Mega everything.
Dr. Lee, are you going to, you haven't operated on this patient before. You got the special tools, right, and the special skills. Are you going to consent for everything that Dr. Welsh is?
It's funny, we were just discussing this in the car ride on the way here, and they were calling this the Australian Grand Slam, the bilateral endoscopic medial maxillectomies, the sphenoid shot, and the draft 3. I think I'm still relatively conservative. I think I would do a full house FES and the draft 3, but not necessarily the endoscopic medial maxillectomy and the sphenoid.
Yeah, Kevin, do you really have to do the maxillectomy on these patients?
Why
this is the reason. Here's the reason why.
Because seem to get better.
10 or 15 years ago, we saw poorly done maxillary antrostomies. I'm seeing far fewer poorly done maxillary antrostomies now. So if I go in there and I clear out the polyps and the maxillary sinus is open, I haven't really done anything for that patient other than remove the polyps.
But don't
so
you think
I want to improve access for this patient. I want to increase my ability to monitor. I want to increase my ability to debride. I want irrigations to get into these sinuses much more effectively. And I'll show you some stuff a little bit later where I think that's beneficial.
Oh, teaser, thank you. Eric, I haven't heard of septoplasty. What about a septoplasty in this patient? Now, we could go back and look at a CT scan.
Yeah,
but should that be part of your routine consent? And I'll tell you why. When you look in the nose, you cannot see the septum. In the septum, the bone is often thinned out because of the chronic pressure from the polyps, and you just sometimes don't know. My recommendation is to consent for the septoplasty in these patients, because it stinks to get in there and wish you would have done it or wish you would have consented, or to have to break scrub and go talk to a family member and say, hey, by the way, do you mind if I move the septum over? Anybody agree or
I
disagree?
included
with that?
in my consent, as I mentioned yesterday, I included in my consent process for sinus surgery, if we need to do the septum for the ability for you to breathe better or us to be able to surgically aerate the sinuses better, I include that as part of a standard consent for endoscopic sinus surgery.
Coming from the guy who yesterday said, if you think septoplasty, do septoplasty.
If you think septum, do septum. Yes.
I like that. That may be my new bumper
I had
sticker.
one more comment here. It was just about, I don't know if it's a function of the system that I work in, because I'm Canadian, that I get a lot of information about the how big, whether it's Grand Slam or not, to do surgery by virtue of their response to topical therapies. And because we're not going to be in the operating room next week or 2 weeks from now in Vancouver, this person can come back in 6 weeks, so I can see on pulmocord irrigations if they've actually had a change to the character of the polyps, the density of those polyps. And I'm waiting for Kevin's lecture so I don't steal any thunder about typing, but not all CTs that look like that need the massive surgeries. And you really can't tell except for the character of what we see. And I don't like making that decision only on surgery day because they've been pre-medicated with steroids and antibiotics and they can look better. And so I want to see that character of the polyps. The things that help me decide are density, tenacity of the mucus, submucosal inclusions, things that give me an idea that this is poor mucosal health that is not going to be amenable to just topical therapies, in which case they get big hole surgery.
Dr. Lee, what's your preoperative steroid management? And we'll go to Mark.
So I usually just do 20 milligrams a day for about a week. I don't think there's any hard, fast rule. Some people do a higher taper, but that's worked for me and something I'd been doing since fellowship that Kennedy used to do. And I do think whatever you decide, that oral steroids is really useful in these patients.
Great. Mark, did you have a question? Question? Yes? Yes.
If I may ask Dr. Welch. Dr. Welch, would you focus and help us see that conversation you held with patients in the buy-in period? That is to say, to express the limitations that surgery will have and the ongoing need for medical therapy. What sort of a discussion and how long does that take and what sort of visual aids do you use to help the patient understand the application of topical medications? I'm just wondering if you focus on that conversation you have.
I don't have very many visual aids, but I do have handouts about irrigations, and I do have some handouts with anatomy. What I basically tell them is that in many cases, these people have developed asthma and polyps and CRS in their adulthood. So I start with the concept that their surgery modifies their anatomy. And I start with the idea that they don't have chronic sinusitis and asthma because of their sinus anatomy. So the surgery that I'm doing is simply opening up their sinuses, after which I can deliver medications because, and I tell them repeatedly that chronic sinusitis, as is asthma, is a medical problem. That surgery helps people get over the hump. Dr. Kennedy would talk about it as being the first step in a 12-step program. And I think there's a lot of truth to that because what I tell patients is this is the first step in getting you better. Everything after that surgery is medical management. And they know from the past, because they've had surgery before, and they say, well, my polyps came back in 6 months, or in 2 years I was in the same boat. So they know this is a recurrent problem. But once I identify patients who, well, I wasn't using steroid rinses, or I was on steroid sprays for about 6 weeks and then I kind of stopped, I think after driving home that point of it being a medical problem and a chronic medical problem that has no cure, and I do often say that there's no cure and that surgery is not the cure, but they will be a lot better after surgery if they follow these instructions. And that talk for some people can take 5 minutes, and for some people it can take a half hour, which is frustrating. But I think the conversation, some people get it right away and some people don't understand it. So it's just like with everything.
Yeah.
Actually, I had 2 questions. First question is smoke, social history in terms of smoking. If, say, the patient was an avid smoker, does that change your surgical plan? Do you require them to not smoke? And the second part was, if you plan this Grand Slam surgery, how long do you estimate it to take in the operating room?
Kennedy used to tell us that he would never operate on a smoker.
Yeah, he would actually not operate on smokers, but I still operate on smokers.
I do all
I
the
want to give
time.
them a chance.
Yeah, I don't think I have as much ability to exclude smokers. I don't know that there's a whole lot of evidence to suggest anymore that there's poorer outcomes.
Especially with good topical therapies, I think that it has equalized things a bit. I think it'd be hard pressed to discriminate based on your smoking status. I do counsel about cessation. The timepiece is a hard one because we don't know what we're going to do. I think the answer has to be about each of the approaches that you saw yesterday in the lab are modular. And you put them together as you need. So if you open up that maxillary sinus and it looks beautiful and you've created a large antrostomy without having to touch anything about the inferior turbinate and there's no internal scarring that's making pocketed areas, don't do anything more to that maxillary sinus. And so timing is a very difficult piece of the puzzle. You can do your best to run through scans, but that's also personal. It takes me an amount of time to do a draft 3 that might be different from my colleagues and maybe I'm not even going to do that. Maybe I'm just going to do some kind of portion of turbinate resection to create a cavity to the ethmoids that I think is appropriate for topical therapy delivery. So I don't think there's an answer about time. I could tell you my time, but I don't know if that would be your time.
Yeah, just to clarify that issue, I mean, in that CAT scan where you see these completely opacified maxillary sinuses, you're looking at a CAT scan, and you have no idea just on that CAT scan. I mean, sometimes you can look at the differential densities within the sinus and tell whether there's mucosal thickening and insubstated secretions. But sometimes we get in there and we just take out the polyps of the middle meatus, and then all you see in the maxillary sinus is maybe a little bit of hyperplastic mucosa, and it's filled with sort of mucus. In that situation, I would not do a medial maxillectomy. But in those cases where I look in there and I see this incredibly dense hyperplastic mucosa and thick inspissated secretions, that patient's getting a medial maxillectomy. And a lot of times I can tell that ahead of time just by adjusting the windows on the CT scan. But, we do a lot of in-office CT scanning, and there's no soft tissue differentiation in those scanners, so it can be very difficult to tell. But, with residents, my average FES time is about 3 hours for a complete FES. And if I do drilling, it probably adds another hour into that.
All right, thank you. I'm not going to show much of the surgery. It's just a standard polypectomy, and I'll just throw out the recommendation. With polyp patients, I tend to do a greater palatine injection. PJ Wormald did a nice study about that. I'll also use hot saline irrigations. Is there anything else you guys add in that you do differently from your normal sinus surgeries when you're dealing with polyp patients from a surgical standpoint?
We talked a lot about preoperatively, so appropriate preoperative treatments. If it's really hyperplastic, use more steroids. If there's a significant infectious component, more antibiotics. So I prolong that and I tailor it to the patient as opposed to having a regime that works for me. Head of bed elevation, I think, works very well if you can get a bed that goes low enough and if you're tall enough, so I have to be a little taller than I am, to get the bed actually elevated. If you use your iPhone, you'll be surprised how much 20, 30 degrees is. It is much more significant than you think. Yes, warm saline irrigation. The nurse doesn't just bring it out of the warmer. You actually have a fluid warmer. I think that's a big difference. Because when you want it and then get it, it's just not the same. Topical medications during surgery, 1 in 1,000 adrenaline on patties.
Great. All right. So this is what we want. Right? We're hoping for a complete ethmoidectomy, beautiful ethmoid cavity, everything's open, life's good. But this is the reality, if I can get their slides to advance. So this one, and you can see it coming across, he's back. All right, he did not do as well as I had
That's
hoped.
what he looked like. What was the post-op time?
The time's about a year here, so.
Was that him in the immediate postoperative page, the endoscopic video you showed? Or no, that was a different patient?
That was a surgical patient. No, the endoscopic one was a totally different patient. That's who we want to, that's what we want to do. This is not a recurrence because that patient's not going to recur. Yeah. That mucosa has normalized. So that's a reality. And this happens to all of us, but essentially there was some areas of incomplete surgery. I could have gone a little bit more, could have done a Lothrop, and we'll show you the end result of this patient. But from a post-operative standpoint, we've talked about budesonide irrigations. We've talked about all the medical things. I do want to highlight the position of irrigation is important. And no, that's not me. This is from Richard Harvey's. I gotta tell every one of my patients, I have a little bit more hair. That was Richard Harvey's fellow. But if you truly want to get the irrigation up into the frontal sinus, you have to tip the head forward, the vertex down position. Otherwise, only 20% of frontal sinuses get penetrated with irrigation after a standard draft 2A. 20%. So you have to tell your patients to get the head down. And this is a picture that I have in my irrigation handout. And everybody with frontal disease, I tell them, you got to bend your head over or it's not going to get up into the frontal sinus. What do you do when it doesn't work? I'm going to go over a couple things in the last few minutes. Anybody using the steroid-releasing in-office stent that lasts for 3 months? Yeah, so it's interesting. It's another thing in our armamentarium of treating these patients. It delivers mometazone for 3 months. Patients have to have had an ethmoidectomy, and there was a nice randomized study that compared it to Nasonex, and they showed a significant 30% reduction in nasal obstruction and 74% reduction in polyp size. Now, that's nice. It gives me the enthusiasm to try it. So on the right, nice and wide open. This is a different patient, nice and wide open. And these are the dense polyps that Dr. Welch was talking about. I'm kind of pushing it in there, reaming it into the left ethmoid cavity. But this is a patient I did not do a septoplasty on. And if you look at this, I can't get this 7-millimeter implant in there, at least not without numbing up the septum, which I did with injection of 1% width. And I finally got it up and over the inferior turbinate and into the middle meatus. So that was a challenge. And I'm thinking I should have done a septoplasty on that patient. How does it look like 2 months later? It's better, quite a bit better. A little bit of crusting, but the patient's feeling great. He's very happy, wants another one. What about that left side where I didn't really get it into the right spot? Did it get better? And you can see that even the septum has decreased edema compared to where it did. And it's a little bit dark from my side, but there's a polyp right there in front of the maxillary os where one of the little legs of the implant wasn't hitting. But as you see up in the ethmoid cavity, it is better. And again, he's feeling better. So it is an option that I would encourage you to consider. It's a lot easier if they have a straight septum. This product, which is, again, I can't say the name brand. It's an exhalation delivery system that sprays Flonase, essentially fluticasone, up into the nasal cavity with improved distribution. You put one end into your mouth, the other end into your nose, and you blow, and it distributes it better. There's a study that shows improved nasal congestion, rhinorrhea, smell function, facial pain, and pressure when compared to a control or the same delivery system without the steroid component. And so that's one of the challenges is I'd love to have a study that showed it versus a nasal steroid spray. It is a bit expensive. The prescription process is a little bit more challenging and daunting. Does anybody have any experience with this? My 1 or 2 patients that I've used it on, it has worked. They have been happy with it, but it was a lot of effort to get it into their hands. And the reason I chose to use it was they did not tolerate steroid irrigations.
I've been pleasantly surprised by it, actually. The patients that I've had on it have been very happy. And I think part of the reason why I realize is a lot of them maybe weren't that compliant with the budesonide rinses, even though they say they do it twice a day. Maybe it's more like once a week. And this just seems a lot easier for patients. I also think it probably does distribute a little bit better into the higher sinuses, so the frontal recesses, the superior ethmoid cavities. So I've actually been pleasantly surprised by it.
Great. So let me show you what happened. I took that patient back for a draft 3, just as Dr. Welch would have done up front, and put a steroid-releasing stent in. I do that to hold my mucosal grafts anterior and posteriorly, and this is what he looked like. Not quite a year out. I just saw him recently. He's about 10 months out now. Did not do a medial maxillectomy.
Did you do the medial maxillectomy? No.
No, but again, just a nice result. And it's not the surgery, it's the delivery of the topical therapy is what does it. So that's really the take home that I think we're all saying. And I encourage you also to consider, this is one of my favorite, this is the classic Tim Smith Fellow publications, and they showed the presence of, they looked at over 40 surgeons and over 2,000 patients, and they looked at what were factors that led to revision surgery in polyp patients. They found polyps had an increased risk of 100%, 107% of needing another surgery. Septoplasty decreased that rate of revision surgery by 30%. Why? Why would that be? And the only thing I can figure out is exactly why I chose to show you that implant case, delivery of topical therapy. Better debridements. It's all about getting the medicine where it needs to go. So
I think it's compounded. It's you do a better job in the operating room, they do a better job afterward, you do a better job at debridement stage. It is, if you think septum, do septum. Have a very low threshold to address the septum.
I think we got to end on that. So thorough, complete endoscopic sinus surgery, which means if you see septum, do septum. Septoplasty, if indicated, topical corticosteroids. And just aggressive medical treatment. Let's remember that we are medical doctors, not just surgeons. And let's be smart about treating polyp patients so that we change their paradigm. Yes, Dale.
Got a question for Dr. Welch. On that CAT scan, it seemed the osteoneogenic bone formation was back in the sphenoid.
Dr. Ayers, talk ready.
And I guess I had been under the impression that the disease, generally starts anteriorly in the sphenoid, the last one to take the hit. Is that true or not? Or because I didn't see any bone formation anywhere else other than way back in the nose, and I just wondered Dr. Welch's thoughts.
Yeah, I don't know. I don't know any evidence to that process in terms of starting anterior and moving posterior. Maybe I'm ignorant on that, but I've seen lots of cases where we just have purely sphenoid osteitis, and that's in patients who have not had surgery, in patients who have had surgery. Maybe it's a little bit more challenging for people to get into the sphenoid sometimes, or there's been some cautery around the SPA in that site's inflammation or incomplete treatment of the disease. But I don't know that there's a process by which it starts anterior and moves posterior. I'm not aware of any of that.